So good morning. We've heard a lot over this morning's big sessions on kind of the standard of a quality of care that you should all expect when you're being treated for your disease. And just like symptom management, in addition to the drugs and the trials and the research, managing your symptoms and also looking at, as those symptoms worsen or even when they start, what other kinds of resources do you have? So we would be remiss if we did not talk to you, both in this kind of a conference and also in our daily clinic time with you, about palliative care, hospice care, advanced care, end-of-life care, all that encompasses. So today I want to just go through that because it's very important that you just have the information. I was trying to think about how I would start this, and I thought about what I say to patients in the clinic, which is a very busy visit. And I know you see many of us troop through your room, the physician and the fellow and the nurse practitioner and the research nurse and the database person, and it's a busy time. But it doesn't mean that this is not important. The symptoms, what you're thinking about that may not want to ask, and it seems like it's too busy to ask. So we just want you to have that construct that this palliative care piece is just as important as hearing about the trials and the drugs and how to manage your symptoms. So I would like to go through kind of what we think of as advanced care, or really meaning care that you need because now you're having symptoms, which were just reviewed there. And then it's very interesting looking at how we're doing right now. How are we using these services? How are they talked about, both on our provider end as well as you on the receiving end as a patient? And then, of course, what we can do to help all about you and us do this better. So I would like to just use the term advanced care for those types of interventions that you need when you develop symptoms. You can no longer have that quality of life that you're used to, and what are your options? So there's many ways to do this. The choices include everything from going into an intensive care unit and being placed on a breathing machine when things get really maybe acutely bad. You get a pneumonia or an exacerbation that really came upon us. We weren't planning on that. You may end up on just a general medical unit. You may be in home care with hospice, taking care of you at home, and the treatments are really not helpful, and you're really having more symptoms that we want to make you more comfortable. Home care, maybe by your family. Palliative care, which I will talk about, which is not available in every hospital, but the philosophy of palliative care should be incorporated in your daily care. So you can see there's a huge range of places that you could end up and get your care, and it's important to kind of know ahead of time. So some definitions. So palliative care really is, and this is a World Health Organization definition, I'm going to read it, an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So palliative care should really start at the first time you're diagnosed and are having symptoms. And we know from data that's been looked at that many of you had symptoms for up to a year or more, some of you, before you got a diagnosis. So it may be at the time of diagnosis. It's appropriate then to approach some palliative care, which is really managing your symptoms. So what's the difference between palliative care and hospice care? Hospice is really more of a prognosis-driven service. It's comfort and end-of-life care in the last 6 months of life. And it can include home care, respite care, meaning that the hospice team can come into the home and relieve your other caregivers. Sometimes hospice is provided in the hospital. It can also be provided in long-term care facilities. The hospice nurse can actually come into that environment, the whole team. And it's really focused on relieving symptoms, providing support to the patient and the entire family, the entire unit. It's a team approach, which is a huge benefit of hospice care. It includes physician, nurses, social worker, spiritual counselor, volunteers, home health aides. So it's a very multidisciplinary approach, as is palliative care. But I think home care is more of a tangible team. So palliative care really is the big category. Hospice really falls within that. So this is just one pictorial that I found. So palliative care addresses all of the symptom management. Within that, you may end up with a choice of hospice when you're more focused with end of life. Your priority may be just pain management in some patients, not so much with our IPF population, but in other conditions. During palliative care, you may well be receiving treatment. You may be in a clinical trial. You may be receiving infusions in some cases. So palliative care does not mean that you've stopped treating the disease. Hospice is a bit of a different focus, and that's more dealing with the prognosis and end of life when the treatments may be stopped because you're not having an effect on your disease status. So again, palliative care is available in many but not all hospitals. But I would hope to convey to you that even if you don't have a formal palliative care team, that the philosophy should still be incorporated into your care. It's covered by most insurances. Provides pain and support, pain and symptom control, emotional support, caregiver support. This is the treatment of the whole family unit or friends support. Usually it's an outpatient service. So palliative care is typically outpatient. You come into the clinic, you may be seen by the team, but if you're an inpatient, we can also call for a palliative care referral. So it can be both. It's appropriate at any stage, and I really want to emphasize this because we are as guilty as others in not thinking about this early enough. When we might suggest to you that you would benefit from seeing our palliative care service, it's not because it's end of life. It's because we want to palliate means to ease. The word means to ease. We want to make your life more comfortable. We want you out and about, engaged, and as comfortable as you can be. So the palliative care team has the time to focus on those symptoms. We don't have that extended time in the clinic visit, but it's important. So any stage of disease, it includes getting medications, so medical treatment and non-medical type treatment like massage, maybe some hypnosis or hypnotherapy, relaxation techniques, yoga, those sorts of things. You keep all your same positions, and again, it assures, most importantly, that your wishes are being honored. So hospice care is actually more commonly offered in hospitals than is palliative care services. It qualifies for a Medicare benefit if your life expectancy is estimated at less than 6 months. As we tell some patients, we'd love for you to get kicked out of hospice. There's actually some data looking when patients enter hospice, they actually improve because their symptoms are so well addressed. So if you're beyond 6 months, you're kicked out, that's great. Again, providing pain, symptom control, emotional support, and importantly, caregiver support. Typically provided at home, but again, some hospice groups can come into the acute care setting and also into the long-term care settings. And it's a team approach, as I described, and again, most importantly, assures that your wishes are being honored. So palliative care can begin at the time of diagnosis. We want you to have those symptoms addressed early. Hospice care is really more of a prognosis-driven service, focusing more on care during the final stages of disease. So let's just give a scenario, a couple, because this can happen in many different ways. You all are very different in the way your disease progresses, the bumps in the road that you come across. So you may get a flu virus, it's flu season. You become more short of breath. You're calling in as we want you to with your symptoms, but maybe things really have rapidly progressed, and we're saying, the best thing to do is go to the emergency room. So you get a typical workup in the emergency room. They take your history, exam, chest x-rays, maybe a CT of the chest, take a look at your oxygen levels. Maybe they swab you for viruses to see if you have a flu virus or influenza. And you go on to get treatment, which could include antibiotics and antiviral if they think it's flu, maybe some steroids if they see inflammation on your scan, either IV or oral. Maybe a nebulizer treatment, oxygen, and you may be sent home. Maybe it was, it's resolving. They can see it's not as severe that you need admission, but maybe you get admitted. And in the hospital, the level goes up a bit. You may get high flow oxygen, and you may be looked at your heart, how it's functioning, echo. Maybe they do a bronchoscopy where they actually look into your lung, take a sample to see if there's infection or something going on. The level of care certainly goes up. And sometimes, if things have really progressed, you have IPF, hopefully we know you, we may decide that this is a time to do a rapid workup for a lung transplant. That's not how we want to do it. We always want to see you much earlier and have that as a choice under a more controlled environment. But sometimes we don't plan it, and you have this acute exacerbation, and we can admit you and do a rapid workup for lung transplant, or transfer you to a hospital that might do that if that's potential. So as time goes on, you may improve. Maybe things start to clear up on the X-ray. Your liter flow that you need for your oxygen levels able to come down a bit. But maybe they're still thinking about maybe you might need a transplant, but it's not as urgent. Or are you going to be discharged to get palliative care with symptoms or hospice? And we keep following you. But if there's no improvement. If there is improvement, then there's a different scenario. But this scenario can happen obviously more than once. Many of you have been through this. Many of you have never had this happen. But it's just a scenario that you want to think about, and that we want to educate you to think about these choices ahead of time, so that you can discuss with your family what you would want done in this situation. It can change once that actually happens, but we want you to have these discussions, and we want to have the discussions with you about, what are your choices? It's very scary, I know, and I don't know as you know, but on those visits, when we feel we have to broach the topic of, you might be looking at a lung transplant, or, it's really getting tough here. I always look back, and I think we would be remiss if we didn't bring that up. Even though it's difficult, I feel it's doing a disservice to you to have you, months later, you end up in the emergency room and nobody told me it could get this bad, or nobody told me this could happen. So we really want you to be well educated about choices and being able to plan. So this is what could happen. This is just a chronic lung schematic. This is not so much IPF or ILD, but these bumps in the road come along and eventually passing away. We often, as I've said at the bottom here, there's some key messages. The courses of many types of pulmonary fibrosis can be prolonged, variable, and unpredictable. There's many of you in here who have been stable for a long time. There's others who have had these bumps in the road. So we can't always predict how you're going to do. A lot of the talk on the genomics and the biomarkers, we're trying to learn from that how we could predict who's going to have these bumps in the road, which would be very helpful. It can be unclear when and what type of advanced care is needed. Advanced care is more than drugs, and physicians are not good at accurately predicting end of life. So a lot of times people say, how is it going to go? How am I going to do? And sometimes we have to say, well, we'll see how you do when we see how you do. I mean, we track your breathing tests, at every the visits, and see how you're generally progressing. But I think what's important here is that the palliative care, we're treating your symptoms all along the same time we're treating your disease. So they don't happen separately. They should happen together. So how are we doing right now? How do we currently use these services, and how aware are patients and providers of providing these? Well, Dr. Lindell here did look at 277 patients because she was interested in how well we're using palliative care, end-of-life care. Many of our patients will say to us, I don't want to die with a lot of machines. I don't want to die in the hospital. But Kathy looked at this background of palliative care and how it can reduce symptoms in patients with IPF, but we don't know how it's being used and if it's being used. So the purpose of the study was to describe the time and course of events prior to death in patients with IPF managed at a specialty center. And what she found is of the 277 patients, over half died in the hospital. So even though patients are telling us that's not what they want to happen, many of them are still having that happen. And a very low, 13.7% received palliative care referrals, very late in the illness. So we know we can do this much better. This was a UK group that have done a lot of work looking at, are we using palliative care? This was a study, palliative care for patients with advanced fibrotic lung disease, a randomized controlled trial of a community case conference intervention. So interestingly, the UK government recently had some legislature dictating that they should improve the care, the palliative care in patients at the end of life. And the question they looked at was, could a palliative case conference intervention improve palliative care concerns, and was it feasible in patients with ILD? So they recruited patients with interstitial lung disease from both in the hospital and outside of the hospital, and the patients were actually randomized to either immediately upon being discharged receive in the home a case conference with a team, a care team, or the other group got discharged home, but only a month later they got that intervention, so it was delayed. So the case was led by a nurse specialist with the patient and their family, reviewed all their concerns, how their symptoms were, what their worries were, and then developed an action plan. And the way they measured how effective it was using a written questionnaire, this palliative care outcome scale. So you can see the group that went home and immediately got the treatment dropped their score. This is the score on the questionnaire, lower being better. So their group immediately was less stressed. The group that had to wait was stressed for the month that they were home, still not doing as well on this questionnaire. But as soon as they got this case conference, their scores came down. So even though we may not do a study, this tells us that talking to you and your family about these concerns helps relieve some stress and alleviate those the stressors. So another comments from this intervention was that this is some quotations from the study. Before the case conference, patient and caregivers stated they had very little knowledge of support that they were entitled to, and that they felt like they were suffering alone, which kind of ties into the talk about the isolation. Through the case conference, patient and carers had access to specialist community palliative care that routinely support patients and carers' holistic palliative care concerns, and they felt this reduced anxiety. And the last bullet point there is that they were grateful for a clear crisis management strategy. When you have this happen at home, what should you do? Who should you call? So they really went through them with them to have a plan, which I think, again, alleviates that stress. So a different approach, they also just looked at chart notes. This same group just went and looked at chart notes of patients that were hospitalized, 45 interstitial lung disease patients, and simply determined by looking at the notes, what were the symptoms, what treatments were given, did they use palliative care, did they address end-of-life concerns. And they did an audit. So their results were that about half received opioids. So these are narcotics, morphine-like narcotics that are very effective in tiny doses of relieving that shortness of breath and the anxiety that can come with that. About a fifth of them used benzodiazepines, again, more like a Valium that can decrease the anxiety, and 4% antidepressants. 0% got spiritual care support. About a third received palliative care. And only 17% of the patients had in their chart documented a discussion of something about where they would like to be taken care of at end of life, either in the hospital or at home, and where they would like to die. Would they rather be in a hospital or would they prefer not to be? So again, we can do this better. So Dr. Holland, who you've heard speak perhaps on pulmonary rehab from Australia, did a study with the pulmonary rehab groups because pulmonary rehab is very multidisciplinary, and if any of you have attended, you know they go through nutrition, exercise, how to know when to call the doctor, how to use your oxygen, the medications. And in many cases, they talk about end of life, but not universally. So Dr. Holland asked the question, what do people with ILD want from education and pulmonary rehab in terms of preparing for the future? So we know that rehab can improve your exercise tolerance, can decrease your shortness of breath, fatigue, and we know also that patients with interstitial lung disease may have different needs than those with COPD and emphysema. So they had a semi-structured interview, and they both interviewed both physicians as well as patients. And these are some of the interview questions that they asked to the patient. What kind of information do you think is really essential for people with ILD to know about their condition? What kind of information do you think would be useful to cover? And to finish off, if you could give health professionals one piece of advice about educating people with ILD about their condition, what would it be? And then they asked the clinicians taking care of patients, similar. What kind of information do you think is essential for people with ILD to know about their condition? And for people with ILD, what kind of information do you think it would be useful to cover during pulmonary rehab? And people with a wide range of ILDs might be in pulmonary rehab. How do you think the educational needs change or vary by their diagnosis? So, I'm sorry. I have a slide out of thing. Excuse me, I was out of order. So the results, she had 18 patients give responses. The strongest theme was from the patient's perspective, was for their pulmonary fibrosis physicians to be honest with them about their future, discuss their prognosis, and discuss end-of-life planning, even in a group session, although there were a few that said that they would prefer it in private. The clinicians responded that pulmonary rehab was very beneficial, but the majority felt that a group setting would be difficult and not appropriate to talk about end-of-life planning because patients would be so different among their needs, which is true. I mean, that is very true. But I think it's an example of hearing that you want to know. So even in our clinic visits, when it's difficult and that's looming in the room, it's difficult to raise the question. We would love for you to be the advocate and make us address it if we don't address it first. But what the data is telling us is that people do want these discussions. Go back one. This is just another type of an example of using a kind of a palliative care coach. This was actually done at Stanford. I just happened to go to Grand Rounds a few weeks ago in our division, and there was a physician who has started a project looking at having patients write a letter, and I'll talk a little bit about that. And they looked at how they could help patients with their symptoms, especially when they went home. So they looked at 105 patients who had a terminal diagnosis. This is not just pulmonary fibrosis. And they randomly assigned them to these two groups. And one group was assigned a layperson who was trained in kind of being a patient advocate and managing patients to help get their symptoms taken care of, and was trained by those physicians. So they found that the group of patients that had this lay coach assigned to them, 80% of them had completed their advanced directives, whereas the group who did not have this kind of advocate to help them manage their symptom and disease progression, only less than half had addressed advanced directives. In the chart notes, 95% of the treatment group with this coach had documented their goals of care, kind of what they wanted, versus less than a third. There was no difference in the use of hospice. The group with the coach had fewer emergency room admissions, so they had a better plan in place. And the coach really encouraged these patients to advocate for themselves. So this was in actually our local newspaper, the San Jose Mercury, down by Stanford there. And front page, huge increase in the need for palliative care. Well, not all of us, baby boomers, we're all living longer with chronic disease. There's a huge aging population, and they find that these needs are way up. So this is good news. I was delighted to see this, that people know about palliative care. They actually realize that there's a need for this. They found that the hospitals with fewer than 50 beds did not offer this service, which makes sense. I mean, so it's something that was addressed by state funding agencies in ways that they could improve it. And then this is came out in the Stanford Daily newspaper. This is the project that I'll talk to you about that I just talked about, her care coach. So what can you do? And it's not just you, it's us. It's all of us. And like the session preceding, it's very important for your input. The Care Center Network can be a vehicle for this, but we need everybody's input on how we can do this better. There's some things that we know are out there to use. We don't all avail ourselves of the resources. Pulmonary rehab, I think, is a antidepressant support group, palliative care, all rolled into one. And then the maintenance programs, I would encourage you to continue with that. It gives you support, you have input, you have a coach there, the rehab respiratory therapist or nurse. They know you, they know when your symptoms are changing, when your quality of life is changing. So that's really key. ILD support groups are clearly another avenue to get information. The Pulmonary Fibrosis Foundation is always a resource. I think if you're not able to find either palliative care, hospice care, end-of-life care, advanced care, it's a great resource to call. And the Care Center Network, I would hope, can also contribute. There's lots of other resources. AARP, these are they're on websites, and I've given some at the end. Aging with Dignity, Pulse Forms, 5 Wishes. I can give you some examples of these. Talking every visit, raising the question, how am I doing? How are things going? We have a mechanism in our EPIC system. We can look at your pulmonary function test, and I can click one of the views on there, and it graphs it. Our patients love these graphs. We don't want you living and breathing by your numbers. I know it's very stressful because I always say to the patient first, how are you feeling? And then we go over. And we know there's variability in some of these breathing tests. And, how you feel is more important than what's on the paper. But you also want to know. I mean, patients want to know. And the 6-minute walk and the oxygen test. So these can be graphed. And then we can also look at symptoms. How high did you rate your shortness of breath on your walk? Is that changing over time? So do ask us, and we'll tell you. Palliative care, if there's not a clinic, you can ask if there's a clinic in your area. We find it very helpful. My last patient that came back to us after going to palliative care, they spent the entire visit with she and her daughter just talking about end-of-life issues. They didn't talk about breathlessness or cough. They talked about end-of-life. She had 1 hour with this team. That's their expertise. We can't give that in our clinic. We can talk about it, we know you, but it's a great extra resource. So if you're in an area where there's not that, there may be an equivalent, a social worker or somebody else that can spend time with you, or make a time to come back and talk to somebody in our team just to focus on that, perhaps. It can work that way. So topics to think about. This was from Atul Gawande's book, Being Mortal. What is your understanding of where you are and of your illness? What are your fears or worries for the future? What are your goals and priorities? What outcomes are unacceptable to you? What are you willing to sacrifice and not? And what would a good day look like? This is something that I don't think is national. I had not seen it. I know that I have some colleagues that have used it. It's called the 5 Wishes. And it's a paper document. It's online. And it goes through this questions and identifies the person I want to make healthcare decisions for me when I can't make them for myself, my wish for the kind of treatment I want and I don't want, how comfortable I want to be, how I want people to treat me, and what I want my loved ones to know. And this was the Stanford Letter Project. In addition to the group lay coach person, there was another physician. And she saw this gap in care about this communication between the patient and physician. And she started this Stanford Letter Project, which is online. And even though, she did research that documented many physicians say, I don't want aggressive, lots of machines and intensive care units, but yet they were still having their patients undergo some aggressive treatment. So there was this disconnect. So the project encouraged patients to write a letter to their doctor describing what mattered most to them towards end of life. And it actually even has this app that what you fill out in the letter can be put into your advance directives. And it's just really another way to have this discussion. The letter starts out with, I have been reading and thinking a lot about end-of-life issues lately, and I would like to talk to you about them. And then the letter goes on with some blanks that you can fill in, these very thought-provoking questions. And the request is that gets scanned into your record and that it's shared at your visits, and you can update it as you go along. So in summary, this is very important, but we all need to do this better. As clinicians, I know this is very challenging for us, so we really want your feedback on how we can do it better. The way all of your disease progresses and has bumps in the road is extremely variable. We can't always predict it. You all have your own kind of genotype in that respect, as well as how you experience symptoms. Many patients experience symptoms quite differently, but it makes it challenging to know when to talk about advanced care. So we do know, though, that earlier discussions and getting the discussion going and earlier intervention, especially palliative care, addressing your symptoms early so that you can keep exercising, get out, travel, etc., that these early discussions can decrease the uncertainty, the stress of not knowing, control your symptoms, and better meet the psychosocial needs of you and your caregivers. So thank you very much.